Our chairperson, sir, is there, Dr. Rajesh MC?
Yeah, I'm here. Thank you, Dr. Bajwa.
Yeah. Karthik is there, no?
Yeah.
Great.
Artists, welcome to the online ISA PG classes. And I request our Honorary Secretary, ISA National, very dear Dr. Sukhminderjit Singh Bajwa, to give opening remarks. Over to you, Dr. Sukhminderjit Singh Bajwa, and please unmute yourself.
Thank you, sir. As our immediate past secretary, Dr. Naveen Bhotara, said, the tradition is continued. The PG classes, they are very well conducted in the past, and we hope to conduct it more better with feedback from all the quarters, teachers, academicians, because these PG classes will be available on the website also, so that you can, sometime the PGs may not be able to join because of their duties and the hectic schedule, so that they can watch it later on, and very useful for examination. And these classes throw some lights on the facts which are not mentioned in the books also, because majority of the time the academicians, they discuss those things which they learn during their lifetime, and even the books are not sufficient to cover those. So it's a must for all these PG students to attend to these classes or listen to them whenever they get the free time during their operation theater or ICU duties. So the current class today, that is uptake and distribution of inhalation anesthetic, it was during my time, I found it very difficult, because the MAC values, the coefficient, diffusion coefficients, very difficult to recite. And at that time I found it somebody to explain these things. And such a the journey now through all those years, we have got so much good faculty in our country. Even Dr. Ashish is a very dynamic young faculty of our nation, and he will be, at least I think, able to cover all those things, even my doubts which remain till date for all those years. Don't worry. And to help him, our another stalwart, Dr. Rajesh MC, is there. He is a person who's very instrumental in taking the Kerala classes, the PG classes, the webinars during the COVID times. He's one of the pioneer founder of those classes. So we have a renowned speaker and a renowned chairperson to cover those aspects. So I wish best of the luck to Dr. Ashish and Dr. Rajesh for continuing this class, and hand over the mic to Dr. Josna Agarwal.
Thank you so
Dr.
much.
Bajwa,
Yes, sir.
see, I must tell you, I am overwhelmed with emotions and happiness to see young talent under your leadership taking over. You as secretary, dear friend Dr. Rajesh MC, as the chairperson, Dr. Ashish, who was with me for a co-author in another article, and Dr. Josna and Dr. Nishant coordinating. God bless you all. God bless you.
Thank you. Thank you very much.
Thank you, sir.
Over to you, Josna.
Yes, sir. So for today's session, I would like to invite our distinguished faculty. The speaker is Dr. Ashish Karthik. He is professor at GMC Thrissur, Kerala. Dr. Ashish is a faculty and organizing chairperson for many zonal and state level conferences. He's the editor with International Journal of Medical Anesthesia, reviewer with IJ and JOCP. He's undertaken 3 state medical research projects, and he's a trainer for BLS and ACLS as well, and has got numerous publications, national and international both. Dr. Ashish is the coordinator of SMILE training program for Kerala, and he initiated the pain clinic at Thrissur Medical College, very multifaceted person. He initiated the cardiothoracic anesthesia unit at GMC, devised the Ashley aerosol eliminator during Corona, and he's a member of IRC, MEU, and simulation studies at KUHS. He's also a PhD guide for Kerala Health University. Welcome, Dr. Ashish.
Welcome. Thank you.
I would also like to invite our Chairperson for the session, Dr. Rajesh Munshi. Sir is the anesthesiologist and academic coordinator at BMH Calicut. He is a member editorial board, Indian Journal of Anesthesia, and associate editor, Kerala ASA Journal and BMH Medical Journal. He has got 35 national and international publications. Welcome, Dr. Rajesh.
Thank you, madam.
So over to Dr. Rajesh. Sir, kindly start the session.
Thank you, madam. And once again, thank you, Dr. Bajwa and Dr. Naveen Malhotra. And it's very kind words also. So I should appreciate the national body for selecting this topic. This is very rarely discussed in this forum. And in 2 years, when we were conducting the ISA Kerala PG update, it was never discussed, at least. And as you know, this is a very tough topic, as Dr. Bajwa has spoken in the introduction part. And to make it simple, we have none other than a good academician in the form of Dr. Asish Karthik, who is a good friend of mine. And he's a professor at GMC Medical College, Thrissur. And inhalational anesthetic agents are, as we know, as an integral part of our multimodal anesthesia system concept. So the inhalational anesthetic agents are both taken up and eliminated, as you are aware, by the alveolar gas exchange system. So the optimal delivery and of inhalational agents requires a thorough understanding of at least the factors which influence the uptake, distribution, and elimination and metabolism of these agents. So to speak on this topic, I invite Dr. Asish Karthik. Over to Dr. Asish Karthik.
Hello.
Yes.
Am I audible?
You're audible.
Yes.
So good evening once again to all the stalwarts in anesthesia and great people and teachers over there. Let me express my sincere thanks to Dr. Sukhminder Bajwa sir, Dr. Naveen Malhotra sir, Dr. Josna, Dr. Nishant, and my dear chairperson Rajesh sir for this opportunity. At the same time, let me give my sincere apologies that this has been very shortly arranged, as the invitation Dr. Bajwa sir requested me to do this. And personally, I'm not a big fan of volatile agents as such, but since this has been handed over to me, I'll try my best to make it as palatable as possible. And one more thing, I would like to basically dedicate, or I would like to look it in the perspective of postgraduate. As Dr. Bajwa sir was mentioning, when I was doing my PG, this is probably the last topic I will learn just before the exam. Go to the exam, write it off, and forget it. So that was a scenario. Even after so much of late in time, the situation is the same. Anyway, I'll try my best to make it as palatable as possible. Dr. Josna, am I audible, and can I share the screen?
Yes, you are audible, and please start your screen sharing.
How is this now?
Yes.
Okay.
It's visible.
Yeah. So let me start with this. Is that okay?
Yes.
Yes.
Good evening.
Okay. Yeah. Thank you. So first, why should I learn this? That's my question. Now, I should learn this because, see, although TIVA has been coming up with very faster pace, the volatile anesthetic still remains as one of the best options for at least anesthesiologists practicing in a small setup. I should say like that, in the sense, any anesthesia machine will always come up with a vaporizer with that. So we should know, for a better understanding of how these things work, we should have a basic idea how this thing is taken up and how is this delivered. So that is essentially, it is essentially an everyday's affair for an anesthesiologist. Now, second point why I should learn this is because of the concept that the margin of safety provided by a volatile anesthetic is much better than an IV agent, because an IV agent, if you once administer, it is not going to come back, or you can't do much on that. But see, if a volatile agent, you have that time to time adjustment can be possible, and that is probably one of the reason why it is still the agent of choice in many centers. And as you all know, every anesthesia part, to make it a complete anesthesia, we still rely upon volatile anesthetics. So that is why we should still learn, and why we should still write an essay on an uptake and distribution. So the goal is essentially what is the goal when I use a volatile anesthetic? What is the goal which I am looking at? See, my target is finally my brain, isn't it? So to achieve a specific concentration in the brain, to keep my brain activity down, or to keep my EEG activity down, or to take my awareness down, is probably the ultimate aim which I am going to use, or I am going to have when I use a volatile anesthetic. So it is essentially to achieve a specific concentration at the brain is probably my ultimate aim. Now, how do we achieve this? This is by achieving a specific partial pressure in the lung. And why I say that? Because, as you know, once you inhale, it goes into the lung, it goes into the blood, it goes into the brain. So it has been said that at equilibrium, the partial pressure of the volatile anesthetic in the brain can be equated to the partial pressure of volatile anesthetic in the blood can be equated to the partial pressure of volatile anesthetic in the lung. So that is essentially the basic idea that everybody should have when you think about the volatile anesthetic mechanism of action. So that is a goal. So my aim is to build up a concentration or a partial pressure inside. Partial pressure is nothing but the pressure which is exerted by the gas, by particular gas, when it is in the mixture, which is present in the mixture, if it is supposed to be occupying the whole area by itself. That is a partial pressure. So my idea is to build up the partial pressure in the lung, so that I presume that at equilibrium, this will be the partial pressure in the brain, because we have no methods to assess a partial pressure of brain in any of these conditions. So this is the essential goal, to maintain an equilibrium. Okay. Now, with that, we should discuss the uptake, the distribution, and the elimination of volatile anesthetics. Okay. Now, this is essentially the topic. Now, the journey of a volatile anesthetic starts with this. As you can see, if you consider this as the common gas outlet, the volatile agent comes out, which we can call as FGO. This is a volatile anesthetic which is coming out of the common gas outlet, to which you are adding your oxygen also. So in turn, what you are getting here, which you call at the mouth of the patient, which you can call by Fi, will be definitely be diluted from the FGO here, because of the added fresh gas flow, the absorption by these circuits, the collection, and the expelled gases outside. So all these factors affect this. So our idea is to learn how a volatile agent, which starts its journey from the common gas outlet, reaches at the inspired concentration at the mouth. So it is essentially this what you are going to learn. Now we will see. Yeah, please see this. The Fi, or the fraction of inspired volatile agent, is essentially obeying a first order kinetic. first order kinetics. Now, we already studied that the FFGO will be definitely more than that of phi. So once they obey the first order kinetic, you can learn this formula and write this in your answer sheet, which can fetch you mark, which essentially says that this is actually a function of the various components associated with that. See, for example, the time and the time constant. Now, what is important you have to learn here is this value. This is the time constant. Now, what is essentially a time constant? Time constant is nothing but it is the capacity of the circuit divided by the fresh gas flow. Capacity of the circuit divided by the fresh gas flow. Now, there are a few more points which you can learn from here. Say, for example, here. See, if I consider what is the characteristic feature of a fresh gas of a first order kinetic. First, I told you it obeys the first order kinetic. What is the characteristic feature? The characteristic feature of a first order kinetics is that almost 95% of the concentration is reached by 3 time constant. So what you are targeting is 3 time constant. So I can actually give you an example with this. So in order to make you easy to understand, for example, if we are using the total volume of this circuit as well as the bag as considered as 8 liters, and then if you are keeping a fresh gas flow of 2 liters, so you know what is the time constant. One time constant becomes 4 minutes, isn't it? So based on the essential idea of this, that is first order kinetics, 3 time constants give you almost 95 concentration. So I can say that 3 into 4, this is a 4 minutes, that is approximately by 12 minutes I can achieve the maximum concentration. So this will essentially give you another clue that in order to increase the Fi, you can actually increase the fresh gas flow. If I increase the fresh gas flow from 2 liters to 4 liters, essentially it becomes 8 to 4 because one time constant becomes 2 and 3 into 2 becomes 6 minutes. So by increasing the fresh gas flow, I can actually reduce the time constant and I can induce the patient fast. So this is another concept which we should keep in mind when you think about the fraction of inspired volatile agent. I hope the point is clear. One more point which you can remember here is another point. Say a flow of 4 liters, more than 4 liters, anything more than 4 liters can push the exhaled air out, and that can actually increase the fraction of inspired concentration of volatile agent, because there will be less mixing. The excess air will be pushed out of the APL valve. So remember this value of 4 liters as well. Okay, so that is one point which you can. So I have given you a few points which you can write for exam regarding the first order kinetics. So first order kinetics, the characteristic points which you should remember, and also an example to quote. So these are essential points which you can write on a exam sheet. Now, we have already seen what happens in the, I hope, here, look here. We have seen what has happened till here, Fi. Now, it is entering into the patient's body, Fi. Now, from Fi, if you remember, if this is the trachea, what comes out will be Fi from here. Now it has gone in, and once it enters into the alveoli, it becomes Fa. That is the concentration of volatile agent in the alveoli. So with this idea, you always remember that Fa, the maximum value you can get for Fa will essentially be Fi. You cannot go beyond that. And another point is, if you have to get this value, That means the maximum value of FA, the only process by which you can is to shut down the circulation. As long as there is some circulation, there is some taking up of the volatile agent from the lung. This Fi will be diluted when it becomes an Fa. So now we should know what are the methods which help to equate. So that is my idea. What are the methods which helps to equate Fa as close to Fi? Okay. Now the first method will be, if I increase the minute ventilation, which I can give it in this formula. If I increase the minute ventilation, I can improve and get it as close as Fi. The second option will be if I reduces the functional residual capacity. If I reduce the functional residual capacity, see, essentially, if you have a large functional residual capacity here, that will dilute the Fa which is coming, the volatile agent coming. So in order to keep the Fa as close as Fi, I should actually reduces the functional residual capacity. So that is another concept which you should learn, you should know. So this is one point which you can concentrate. The method by which you increase the Fa is by increasing the minute ventilation and also by reducing the FRC. This actually becomes important when you want to prime a circuit. You can actually prime the circuit with volatile agent initially if in such situations. Like then you can actually reduce the FRC and prevent the dilution. So now we should think about crossing. Now uptake from the alveoli. I told you we have reached the journey from Fi here to Fa here. Now we are crossing the alveolar membrane and reaching the blood. We will see what happens in the blood. So essentially we are going to describe uptake from the alveoli. So uptake from the lung is actually assessed by this formula. Any uptake, we can assess a formula. So blood solubility is actually given, some books give it a formula as lambda and cardiac output as Q. You can write that also, lambda Q Pa minus Pv divided by atmospheric pressure. This formula you have to by heart. This is very important. This you can use it many areas. So uptake from alveoli or uptake from tissue, wherever you find uptake, this is a formula which you have to write. Uptake from the lung is equal to lambda Q Pa minus Pv by pressure. The pressure can be the barometric pressure. Okay. So now you from the formula you can say that any of this component, say solubility becomes 0 or cardiac output becomes 0, that cardiac arrest, what will happen? The uptake actually stops. It becomes 0. So all this component has to be intact to have a proper uptake. So whenever the patient has got a cardiac arrest, hypoperfusion, no blood flowing into the patient lung, that means essentially the cardiac output comes down and becomes 0. There is no uptake of the volatile agent. So this is one formula which I always love to see it on the examination paper. Now, how do we measure? So we have seen from here, it has come up into the blood, and uptake formula we have studied. Now, see, from this formula, some volatile agent will enter into the brain, isn't it? So enter into the bloodstream. Now, how do we calculate the amount of volatile agent that enter into the brain or into the blood? So that takes us to the next point. How do we assess? So assessment of uptake is given by a simple formula, Fa by Fi. So this is one formula which you will be always looking at from now on. That over time, okay, that over time is what we are looking at. So you please see here, initially at 0 time, the alveolar concentration significantly goes up, and then gradually the further rise actually becomes is hampered, and then over time it gets saturated. So Fa by Fi is actually flattened as you go up, and this is especially true with highly volatile agents like halothane. Highly volatile in the sense those agents that mix with blood very high, while less soluble agents, say please see the upper part, the less soluble agents remain at the top. Now, one more point which you can see here, if you remember the desflurane, the blood gas partition coefficient is only 0.42, while nitrous oxide it is actually 0.47. You can always see that we expect the blood gas the value of desflurane should come above, which practically doesn't happen here. This is because of the second gas effect as well as the concentration effect which is exhibited by nitrous oxide. That is also another point which you can remember. So remember this graph, which is important. It is a method to assess the uptake, essentially given by the formula Fa by Fi over time. And remember, highly soluble agents like halothane, they although come up initially, later flattens up, while desflurane, sevoflurane, nitrous oxide, which are less soluble, they actually produce a higher Fa by, the uptake is much faster because they don't mix much in the blood. So that is also another method to assess the uptake of volatile agents. Now, once everything has entered into the blood, now we should know what is distribution. So till now, I hope postgraduates, those who are following, will remember that we have actually started with the uptake. Now we are going to distribution. Uptake, it initially started with the Fi, FGO, then it has gone into the circuit. Here various factors which affect the uptake, we should remember, the absorption, especially with rubber. And then once it has diluted and reached into the Fi, which is inspiration, from there it has again, which we have to use this formula to calculate the amount of the function of Fi and FGO connection. Then from Fi to the inspired volatile agent becoming the volatile agent which is seen in the alveoli. How is it related? What are the factors which affect the concentration of the volatile agent in the alveoli? And then from there, how it is crossed, what are the factors or the formula which determine the crossing or the uptake of the volatile agent from the lung. And this is what we have seen, and how to measure this uptake in terms of Fa by Fi. I hope I'm audible and clear.
Yeah, it's very clear.
Is it okay? I can proceed.
Any
Yes.
feedback from the students?
There are students, please write your questions in the chat box. I think we can proceed for now.
So we'll go to the distribution part.
Okay. Rajesh sir, you can add in between so that I can also relax in between. If you have anything, or you will go to the last. Shall we proceed then?
Yeah, please.
Okay. So once it is entered into the blood, now it is about distribution. Now distribution, there are a few points which you have to remember. Say for example, in this photograph, how do we calculate the distribution? The most important thing to calculate is to find out how the volatile agent, which has actually entered into the blood, will go into different parts of our body. Now, for that, we should understand that a person, Mapleson, has put forward a hydraulic model. So whenever you see distribution in the body, please remember this name, Mapleson and his hydraulic model. This is essentially the basic structure. There are a lot of assumptions. So it is not essentially the correct way how this is happening in the body. It is not like that from one tank it will go to the other. It is not as simple as that. But for learning and understanding, Mapleson has contributed a hydraulic model which is quite popular among academicians. So please understand how this is getting distributed. So what we have here is Fa, and then here we have Fi. That means you consider this tap as the lung, as the output from the circuit, and here you have this tap B. Tap B is the minute ventilation or the ventilation. If you consider, if you open the tap, that means patients start ventilating. It will enter into the lung, the volatile agent. These are the volatile agents constantly flowing into the lung. And from the lung, it goes into 3 compartments as per Mapleson. They go to a vessel-rich group. They go to another compartment called muscle. And they also go to fat, which are vessel-poor group. Now, please look here. We can see that there are a few points which you can write. The vessel-rich group, this one, is essentially occupying only 10% of the body mass, but actually take 75% of the cardiac output. Now, this is, you can see the perfusion is quite high. It ranges from 55 to 500. If you write 50 to 500, it's perfectly okay. This much of perfusion, highly perfused organ. But it's a small tank, small area. But the pipe A is broader. It's a broad pipe. So the circulation is faster. It goes for, it's broad and short. So immediately, as soon as the lung is filled, the volatile agent will immediately go into the vessel-rich group, which is essentially our area of interest, the brain, liver, kidney, and other vital organs, of which this is the target organ. Brain is our target. And others are non-specific and non-targeted perfusion, which we are not bothered much. Now, see the second group, the muscle group. In the muscle group, you can see it is a bigger tank because it occupies almost 50%, receives only 20% of the cardiac output, reaches a bit more slow, and has got a minimal perfusion. Now see another tank C or pipe which take to that, the pipe C, which is essentially a fat, which actually has got 20% of the body mass, very poor cardiac output, but they act as a reserve. This is responsible for the patient to have some hangover effect later, or after recovering, patient to exhibit some amount of drowsiness, is because whatever entered here slowly, once the volatile agent is stopped administering, this may perfuse back into the system, into the blood, producing some amount of hangover effect. This is essentially the reserve or the storage part. Okay, so this is essentially what I would like to add upon with Mapleson hydraulic model. Now, one more point to remember here. As I already told you, that is an ideal model, but it may differ with low solubility anesthetic. If you have a low solubility anesthetic, the tanks are small. These are the points which you can remember. Tanks are small. All components are small, and the pipes are also small. Because it is less soluble, and it is only very less is arriving to the tissue. Less is arriving to tissue. To achieve the equilibrium of volatile agents there, only a small quantity is needed. Now, if you take the other one, high solubility volatile agent, if it is a high solubility volatile agent, you can see that the tanks are big, or all the components are large. That is one point. The pipes are also large. As you can see, these pipes are broader, are large, which means that there are large quantity of volatile agents large quantity of volatile agents reach to the organs. There is one more point which remember, for equilibrium, you need large quantity of volatile agents. Okay, so I've already given you 3 points here. Regarding distribution, you should rely upon Mapleson hydraulic model. Describe the hydraulic model first, give the various components, their cardiac output, their target, their body mass, their perfusion. Now, how they work initially, and then bring out to 2 different spectrum. What we have, one is our low solubility agents and then high solubility agents. So 3 graphs will give you reasonably good marks for that. Now we have reached to a stage that you have started from the machine to the mouth, from the mouth to the alveoli, from the alveoli, cross the alveoli, reach various tissue levels, and from the tissue levels, how do they uptake? Again, the formula is similar. I already told you, if you remember, tissue uptake, any uptake when you see, remember this formula of lambda q Pa minus Pt. Instead of Pv, it is Pt, and divided by the barometric pressure or the atmospheric pressure. So this gives you the tissue uptake. Okay, so there we had alveolar uptake. Now we had tissue uptake. So this is another formula which you can write onto your exam answer sheet. So we have seen all those points about how it is getting distributed. Now we will see how these agents get metabolized. Okay, how these agents get metabolized. Mostly, as you know, metabolism is usually very slow for all these agents, and they are very slow. And initially, the enzyme get exhausted faster. All this enzyme which metabolize these volatile agents get faster, and it is not a big relevance to us most of the time. But it become relevant when it is recovery, when you are thinking about recovery, because recovery may take some more longer time for agents which may need some metabolism and leave behind some agents. At this juncture, you should also remember certain agents like halothane.
Dr. Ashish, just a minute.
Yeah.
There's one query. They want to see the previous slide.
Yeah, I'm sorry, I'm not looking at the chat.
No worries.
Because
Yeah,
this one, no?
yes.
It's the same. Please see the uptake formula is same. Lambda is the solubility, Q is the cardiac output, and there during the alveoli we have P arterial minus P venous. Instead of PV, we have PT here, and then the barometric pressure. Is that okay?
Okay.
Yeah. So the metabolism. So we were talking about, yeah. So we then gave general ideas about metabolism, that usually it is metabolism of these volatile agents are slow, and it is not a relevant significant effect for a clinician, and especially when during an induction time. But during recovery, of course, metabolism do play a role, because delayed metabolism, as in case of hypothermia, comorbid conditions, can affect the recovery. Anyway, not to very significant extent as IV agents. But from exam point of view, you should also remember a few more points about metabolism, like for example, halothane. You should remember halothane, sometimes around 15 to 20% of halothane is metabolized, and this is eliminated via metabolism. As you all know, it can have an oxidative metabolism, and of course, the liver is a major area where it is metabolized, and it can go for an oxidative metabolism and produce chlorides, and the metabolites can be hepatotoxic. At this juncture, you can also remember about the spectrum of hepatotoxicity that halothane can cause. As you remember, the halothane hepatitis, where you can have a small SGOT, SGPT elevation to a spectrum of fulminant hepatic failure. All this can result, especially when you are using a repeated use of halothane, especially within a span of less than 3 months, as most of the books say. Now, the second point which you have to write, other than halothane, is about sevoflurane. Yeah, sevoflurane is one which you know, any carbon dioxide absorbent like Varalime or a soda lime can actually produce compound A. Compound A, which is nephrotoxic. And as you all know, this is a favorite question for your Viva OC, and many of the examiners love to see these names and the chemical formula of compound A. Now coming to, but apart from that, nobody is going to see compound A because it happens in a very low flow rates, and that too proven only in mice and many other. It's only theoretical possibilities. Anyway, as a postgraduate, we are destined to study this, at least during that time. Now come back to the third one. See, other agents like nitrous oxide, isoflurane, desflurane. These are also agents which you need to remember. They also don't have much of a no significant metabolism happening in the body. So that is another point which you can remember. So all these points we should know about the metabolism. So till now we have discussed about how the volatile agents are taken up, how they are distributed, and how they are metabolized. Now with this idea, we will just go to the some bit more points which you can remember as a part of your completion of the essay question. This is a concept of overpressurization. Now, overpressurization is nothing but you try to provide large concentrations of volatile agent to the patient. Now, how do I equate this? I can equate this to something like giving an IV bolus. You can equate this to and administering a, for example, if you want to give dexmedetomidine, you initially give a bolus of dexmedetomidine and then follow by an infusion, or any other agent, initially a bolus, then a maintenance dose. So overpressurization is something like that. It is actually a volatile agents bolus administration. You can call it in that way. So this can be used as a method to speed up the induction. So that is again the use. Suppose somebody asks, so conceptually overpressurization means bolus administration of volatile agent. Now why it is used? To increase the speed of induction. So how is it administered? It is administered by providing a higher Fi than needed for the patient. Say this patient, just conceptual values only, needs 10 atmos of a volatile agent to get anesthetized or get induced. Instead of providing 10 of inspired, I am giving 30 of volatile agent. So this is actually a much higher value which is needed for this patient to get anesthetized. So this is known as overpressurization or administering higher Fi. Now, what is it? How is it related? You remember, administering high Fi can influence both the concentration of Fa in the lung or the alveoli and also the rate of rise of Fa by Fi, which we have seen. I hope you remember that graph which I shown you, this one, like halothane, like this, and then the nitrous oxide and this fluorine of this Fa by Fi over time. So this is actually can be made up, or it can, the Fa can be quite made up very fast when you overpressurize a circuit with volatile agent. So that is a concept of overpressurization. Now it has got two components. One is called concentration effect. When you write about overpressurization, you can write about a concept called concentration effect. The concentration effect can again be divided in having two components for it. One is called a concentrating effect and then augmented gas flow inflow effect.
Dr. Ashish.
Yeah.
Sorry to interrupt. I think there is a request from Dr. B.K. Roy. So please re-explain the IV bolus point. I think he's pointing to overpressurization concept.
Okay. Dr. Roy,
yeah.
I'm sorry, I cannot see the chat right now, but I mean to say that overpressurization is essentially what I'm trying to say is I'm trying to equate, or I'm trying to explain that why do we overpressurize? Normally we inhale with a volatile agent. Instead of that, we are actually giving more than what is required to the patient. Although the patient doesn't need this much of volatile agent initially, with the idea of bringing down the time needed for induction or a faster method to achieve the FA by FI ratio, we are actually providing larger volume or larger concentration of FI to the patient. Just like we give an initial bolus dose and then a gradual smaller dose for maintenance as far as an IV agent is concerned. That is my understanding about this. I hope the point is clear.
Yes.
Okay.
I think he got it.
Yeah, concentration effect. Now we will go to the next aspect, the concentration effect, which has got two components to learn. One is called the concentrating effect and the augmented gas inflow effect. Now, along with that, we have one more concept to learn, which is known as a second gas effect. Now, the concentration effect is nothing but I think I have a diagram with that. Yeah, the concentration, by increasing the concentration of the volatile agent here, those agents which are fast absorbed into circulation will actually bring down the suppose we give FA. Along with that, this is you consider this as a volatile agent. Along with that, we give another agent, and suppose this FA is absorbed very fast into the circulation. You can see that the concentration of the volatile agent, relative concentration of this volatile agent increases very fast in the alveoli, resulting in higher FI of this agent. This is essentially the concentrating effect. And as you know, when the concentration of this agent increases in the alveoli, the uptake will be that will be equated to the concentration of this agent in the brain, because that is an equilibrium. At equilibrium, we studied that the concentration of a volatile agent in the alveoli will be equal to the concentration in the brain. So if there is an increase in concentration of agent in the alveoli, because of the relative faster absorption of the second agent, the partial pressure of the volatile agent get increased in that. So that will result in faster rise in FA by FI. Along with that, the augmented gas inflow says that along with that, what is flowing in is not oxygen. We have also a combination of the same volatile agent flowing into that. There are of course few values to remember here, which if possible I'll explain later. Along with that, we are actually increasing the concentration instead of just increasing the concentration here. We are actually bringing up the concentration more with an augmented gas inflow. In fact, I'll put it in this way. See, if you have a concentration of X in the alveoli and you increase the administration of into by X times, like 5 times, we expect a 5X concentration in the alveoli. Instead of that, you get more than 6 concentration, more than 6X in the alveoli. This is essentially because of the relative increase of this volatile agent, because of the faster absorption of the second agent here, and the partial pressure of this agent increases because of the partial pressure, because of the faster absorption of the second agent. So thereby increasing the concentration in the alveoli. This is essentially the concentrating effect, and since it is also augmented by further flow of the volatile agent from the circuit. This is the augmented gas inflow effect. So this is both this contribute to the concentration effect. One more point to remember is the second gas effect, which is essentially a special case of concentration effect exhibited by nitrous oxide. Now, volatile agent in combination with nitrous oxide is what is usually administered, as we all know, during the induction phase as well as in the maintenance phase. Now, as we know, when you administer nitrous oxide and a volatile agent with oxygen, once it enters into the alveoli, say for example, I consider it as 70, this as 28, or oxygen as 28. And volatile agent as 32. Okay. So this is being administered. Just imagine this is the flow what we are getting into the alveoli. And the moment what happens next is, see here, the nitrous oxide, because of the high diffusing capability, get absorbed very fast into the blood. Now, what will be the end result? It will be something like that. Nitrous oxide will become 35. Volatile agent remains 2, and oxygen also remains 2. The same, 28. So, what was the concentration of volatile agent in this case? Say, for example, what was the concentration of volatile agent in this case? See, this total is 100. 2 by 100 was the concentration of volatile agent in this case. Since nitrous oxide was used, now it became, now what is the concentration here of volatile agent? It becomes 2 divided by 28, this one, 28, 30, it becomes 65. 30, this added up 30 plus 35 becomes 65. See, now you can see the concentration has gone up. So now the concentration of volatile agent in the alveoli has gone up because of the faster uptake of nitrous oxide into the bloodstream. So this is what is known as the second gas effect. The presence of nitrous oxide, if we want to put it in words, presence of nitrous oxide increases the concentration of volatile agent in the alveoli, thereby increase the uptake of volatile agent or the second gas administered to the patient during induction. So these are the 4 points which we will be looking at. 1, 2, 3, 4. So during the second gas effect is nothing but a special case of concentration effect exhibited by nitrous oxide. When you combine nitrous oxide and with volatile agent during induction, whereby the uptake of the volatile agent will be augmented by the presence of nitrous oxide in the alveoli, which due to its intrinsic ability to absorb faster into the bloodstream. So this is second gas effect.
Dr. Ashish, sorry to interrupt again.
No problem.
There is a request from Dr. Teja to please explain the concentrating effect.
Yeah, I'll come to that last because in between when I get interrupted, I had an issue. I'll come back to it.
That will be fine.
Okay.
Yeah.
Okay. So this was a second gas effect, and then coming to the concentration and second gas effect, as you can see, what is its clinical relevance? The clinical relevance is, although second gas effect can be applicable to all the agents, it becomes clinically relevant in highly soluble volatile agents. Say, for example, halothane. Although we don't use it nowadays, it becomes clinically relevant. As you can see that the rise has happened, then Fa by F1, Fa by Fi rise has happened more with highly soluble volatile agents, while poorly soluble volatile agents like desflurane and sevoflurane are not much affected. They are almost the same in presence of nitrous oxide. So that is one point which you can highlight. Okay, so we have studied volatile agents. We have studied a second gas effect, and then how is it clinically relevant? As these are relevant only or more relevant in case of highly soluble volatile agents. Now coming to ventilation, now rest of the part, this is uptake, and then now we have few more points to cover is about ventilation, which rather very simple agents. Now ventilation is nothing but, ventilation, volatile agent are with less solubility, there are no much effect for as far as ventilation is concerned. But a highly soluble volatile agents like halothane, it becomes relevant when you increase the ventilation, because it can control the uptake. By ventilation, we can improve the ventilation also. Now, this becomes relevant in case of spontaneous ventilation and controlled ventilation. Now, for example, as you know, when the patient is spontaneously ventilating, when we take up more and more volatile agent, the breathing comes down, and because the drive comes down, and then further taking of volatile agent is not there. So it is safe. But if you are using control ventilation and you keep on increasing the rate of ventilation without having a look onto your hemodynamics, you are at risk. So highly soluble volatile agents with control ventilation without looking to the ventilatory parameters are risky. So that is one point which you have to remember. So control ventilation, you should always be looking at the hemodynamics when you use volatile agents with a significant cardiovascular effect, because those agents which are highly soluble will be taken up in a very faster rate and a higher concentration to produce hemodynamic effects when you have a higher rate of minute ventilation. So that is one point which you have to remember. Now, till this time, from beginning to this time, I was discussing to you about from one component, volatile agent, going to another component, the transfer. So all this transfer becomes possible, and the basis of this is blood gas partition coefficient most of the time, which we have to study by heart, at least these values. It is nothing but blood gas partition coefficient. By definition, it only means that concentration in blood divided by concentration in gaseous form. So blood gas partition coefficient, those agents with a very low blood gas partition coefficient, say for example, desflurane, we don't have nitrous oxide here. Nitrous oxide is only 0.47. These are agents which are highly with a very low blood gas partition coefficient. That means they don't mix in blood very faster. They enter into the blood, get transferred to the brain, get their jobs done, get eliminated fast without leaving behind any trace. So these are agents which you are always looking at. But those agents with a very high blood gas partition coefficient like halothane, like 2, which has got a value of 2, they actually mix in the blood, remain in the blood, mix, and then only appear as free form, and then they go to the brain, induce the patient, and it also takes so much of time to eliminate from the patient body, resulting in hangover effect. So solubility, less soluble agents are one which we are looking at ideal agents for induction. This is especially true when it becomes daycare surgeries. We are always looking at these agents with very low blood gas partition coefficient or very less soluble volatile agents. Now, perfusion also becomes important. Not only ventilation, but also perfusion becomes important. Now, less soluble agents, the cardiac output doesn't affect much effect on the FA by FI ratio. But those agents which are very highly soluble, again, cardiac output is important, because when the cardiac output decreases, the FA increases, and as the uptake decreases. As you know, if you remember that graph, whenever the uptake from the alveoli reduces because there is no circulation happening here or no ventilation happening here, when this uptake is prevented, the concentration of the volatile agents in the alveoli keep on increasing. And as we have learned earlier, the concentration in the volatile agent in the alveoli is equivalent to the concentration in the brain at equilibrium. So when you have a higher concentration in the alveoli, you have higher concentration in the brain. That's presumption. So this become relevant in agents with high volatile, with a very high mixing up agents. So especially when you use agents like halothane, please be careful to look at the blood pressure and the perfusion. Now, in general, we have to know that there are various factors which affect the FA and FI, which we have already discussed in our previous slides. So I've just tried to summarize this, the relevant agents in this graph. This graph is also important for you when you write all this essay in the exam regarding the various factors which increases the FA by FI ratio. The cardiac output, the higher minute ventilation, the higher inspired concentration, the decreasing PV gradient, and the lower blood gas partition coefficient. These are factors which affect the rise in alveolar concentration in the alveoli, of the volatile agents in the alveoli. Now, a last point about ventilation and perfusion. V by Q, as you know, this also affect any perfusion. So effect of shunt is basically what I want to discuss. So this is more with less soluble agent. The effect is more with less soluble agent. And you should remember that arterial shunt, see the arterial shunt is more affected than the alveolar shunt. In fact, an embolus, a pulmonary embolism become more relevant than an endobronchial intubation. Endobronchial intubation. Although both affect, but you should also know the ventilation perfusion, among the ventilation perfusion mismatch, the alveolar arterial shunt is more affected than the alveolar shunt. The last part of which the elimination. We have seen the metabolism, now we will see the elimination. Now, elimination, there can be three ways to eliminate. One is percutaneous and visceral loss. Percutaneous and visceral loss is done by, is very minimal. It's very minimal. And there are also diffusion between tissues that happens. Here in this juncture, I would like to add a point that initially when we discussed about the 5-compartment model of Mendelssohn. There has been few expansion to that, where they say that apart from the 3 jars which we had, the vessel-rich group, the muscles and the fat, apart from that, there is also one more group which is existent, which usually seen as a fat around the visceral organs, which also accumulate the volatile agents. This is another concept which has come into existence, which can actually, in between, once the volatile agents intake has stopped, this can actually diffuse back into the viscera as well as into the bloodstream and can bring about some compromise during the recovery. So that is also one point which you can add up, that there can be an additional diffusion between the tissues that can happen during the elimination phase or during the terminal phase. And the last point is exhalation and recovery. This is probably the primary route, and this depends upon the solubility of the agent, the cardiac output, as well as the minute ventilation of the patient. This is a graph which you can add to this, which shows the fall or the elimination via route. You can see the less soluble agents are eliminated faster, or their concentration falls faster than the more high blood gas partition agents like halothane. More mixing agents will take more time to reduce to normal, or will remain in the blood for longer duration than the less soluble agents. So this is the graph which you are looking at when you draw in an exam sheet. So exhalation, so elimination, 3 points to remember: the percutaneous as a visceral loss, diffusion between the tissues, and exhalation and recovery. That means essentially the ventilation. One more point, the last point. The last point to remember is all this become relevant when you have surgeries which are prolonged surgeries. See, when you have a comparison between 2 agents with a different blood gas partition coefficient, you can see that it is only minimal in the first, if the surgeries are lasting shorter. But if the surgeries last longer, stays longer, the difference become more and more relevant. So as the surgery is prolonged, the elimination and the duration of anesthesia prolonged, the volatile agents elimination become more time dependent, or those agents which mix in the blood will take more time to eliminate. In clinical significance, we should look for 4 hours. That is the time which most of the books say. Any surgery is less than 4 hours, you don't have to worry much about the volatile agents hangover effects of the agents what we use, isoflurane and sevoflurane. Those surgeries which take more than that is the one where you can think about the hangover effects or more time for elimination in this case. This is also another graph that we will love to see in the answer sheet regarding the elimination. Diffusion hypoxia is nothing but, this is again a few points which you can remember is, diffusion hypoxia is because of exhibited by nitrous oxide. Number 2, this is happening during recovery phase of anesthesia. This is because of the intrinsic character of high diffusion capability of nitrous oxide. Now, what happens clinically is, when we were administering or the maintenance phase was over, and suddenly the surgeon says that surgery is over, and now you can reverse the patient or you can come down on anesthesia. We stop nitrous oxide and oxygen together. That's what they say. And suddenly the nitrous oxide flow has come in, stopped here. The nitrous which was coming has stopped, and oxygen also stopped. What happened was the nitrous which was here in the blood immediately diffused into the alveoli before the oxygen can come in, because oxygen will take time. The nitrous will immediately jump very, very fast because of the high diffusing capability and fill the alveoli, and the whole alveoli will be filled with nitrous oxide. At this moment, what will happen? At equilibrium, we have studied that the concentration of a volatile agent in lung will be equivalent to the concentration in the brain. So at this juncture, the brain will see that full of nitrous oxide in its vicinity, or you can say that the brain is filled with nitrous oxide in that moment. This happens when you cut nitrous oxide and oxygen together and don't provide oxygen. So the way what you do is, when you want to avoid diffusion hypoxia, what you do is, when the surgery is over, nitrous oxide was going, oxygen was going. Along with that, when the surgery is stopped here, you can actually stop nitrous oxide and provide oxygen for longer duration, as we routinely do. So when you provide oxygen, the alveoli will still be filled with oxygen from FI or from the machine, while the nitrous oxide in the bloodstream will be diffusing back into the alveoli. But even then, since there is oxygen supply from the alveoli, from the circuit, you don't have hypoxia there. So otherwise, what will happen? There will be hypercarbia also, and there will be hypoxia along with that, and there will be delayed respiration, or the trigger of respiration will be delayed. So in order to prevent diffusion hypoxia, you have to, once the nitrous oxide is stopped, you have to continue administration of oxygen for little longer than nitrous oxide while reversing the patient. This is the concept of diffusion hypoxia. Again, the concept is the high diffusing capability of nitrous oxide especially into closed cavities. I hope I've kept the time. I'm sorry, I've taken 5 minutes extra.
Yeah,
It,
it's okay,
now,
Ashish.
Can I go to the chat now? Or Rajesh sir, would you like to add something?
No, it was an excellent presentation. I think postgraduates has noted a few short questions like concentration effect, augmentation, gas flow, second gas effect, and diffusion hypoxia. These can come as a short note. And when you get an inhalation agent for Viva, these questions may be asked also. There is only one query, Dr. Ashish.
Yes, sir.
That was by Dr. Teja. for explaining the concentrating effect.
Yeah, I'm seeing distribution. There are so many questions on. Okay.
So there are any
Okay.
questions on?
Yeah, no problem. Okay. I think I'll prepare it once again. If you meanwhile you can add something on this. Meanwhile, I'll get ready with the concentration effect here. Can I change my slide back there?
Yes.
Next, yeah.
Yeah. Okay. Concentration effect is nothing but it is only the process by which you are trying to provide some augmented Fi or increased Fi at Fa or at the alveoli. This is done by increasing the concentration of the flow into the alveoli. Now, when you do that, if you have a agent which can actually diffuse faster into the bloodstream, you have an agent which can diffuse faster into the bloodstream. When you add a small agent, like if I can call it as Fx, if you add a small agent at X, if you can call it as X, if I increase the Fx 5 times the X, the concentration of alveoli, what you expect at alveoli will not be Fx at the 5 times X. Instead, it will be 6. To be precise, it will be something around 6.3, which I got a formula to add, which you can look into the book. This is essentially because the agent, the other agent which was present along with the X, mostly the nitrous oxide, has actually diffused into the bloodstream. And because it has gone into the bloodstream, the relative concentration of the X has gone up, resulting in a higher Fa concentration. So this is what is essentially the concentrating effect exhibited by the volatile agent in presence of a nitrous oxide. They didn't specifically mention nitrous oxide. They say any agent which is given along with the second agent, and the first agent being a higher diffusing capability. Most practically, what we use is the nitrous oxide. So whenever two agents given together, if you want to improve the concentration of the second agent given, the first agent which is given has to be having a higher diffusing capability across the membrane into the bloodstream. So when it diffuses fast into the bloodstream, the relative concentration of the ideal volatile agent seems to increase in the vicinity of the alveoli, causing a higher concentration there, which will be equated to the concentration in the brain. So this is what is the concentration effect exhibited by two agents, one with a higher diffusing capability and other with the lesser capability. Along with that, you are not only giving oxygen, no, in the next breath, you are giving additional volatile agent. So that volatile agent will again add into the concentration of the second agent, which cause further increase. So that is actually, it doesn't stop into 6.3. It again goes above because of the next subsequent minute ventilations do bring about the same agent causing concentration effect, along with that augmenting with the first volatile agent, which you need to increase in the alveoli. This is the concept. If you have any doubt, you can actually go and see. If you don't further understand, you can see a graph which is given in the many of the standard textbooks by which, along with nitrous oxide, which they bring about the increase in the sudden absorption of the nitrous oxide which has happened, which caused the relative concentration of the second agent to be increased in the Fa, causing further absorption into the bloodstream. Yeah, there is a question regarding concentration effect and second gas effect. Second gas effect is nothing but it is we have already seen that it is nothing but a special. It's a kind of concentration effect exhibited by the nitrous oxide.
There is question regarding inhalation induction, its effect on LV ejection fraction during induction.
Sorry, sir, I didn't get that question. Where is that?
That was a direct message. Inhalation induction, its effect on low ejection fraction. I think Dr. Ashish has explained in one slide, initial slides. Low cardiac output, there is a graph.
Yeah. This is it. Isn't it? Was this the question?
Yeah. Cardiac output.
Yeah. So less soluble agents, I've already mentioned, it doesn't have much of an effect on the agent, but those agents which have a higher diffusing or higher mixing do have an effect, which we have already told you. When you ventilate with such agents, please be careful, because it can actually cause significant depression of the volatility of the hemodynamics.
Dr. Rajesh, can I add something here?
Yeah, please, sir. Please.
Actually, this is not a small topic. The questions which are coming for the repetition or whatever they are asking, they cannot be finished in this class only. The next class is a continuation of this uptake and distribution of inhalation anesthetics. Next class we will be having on the pulmonary exchange phenomena with the oxygen and carbon dioxide transport. So many questions will be carried over to the next class also. So we don't have to answer all the questions, because the class will be available on the website, because it is a recorded class. Tomorrow it will be available, so everybody can go through the class once again. It can be recorded. It is recorded, and everybody can see it. And the next week also we will have that same class, continuation of that. So it will be easy to answer in that class also, so that the revision continues just like examination. So that's the way. So you can carry forward from here.
If somebody has any more doubts, as Raju sir has mentioned, I've put my mail ID also. I can send you the explanation also.
Yeah, that is fine, Dr. Ashish. That is fine, because all the questions almost are same repetition or very close to each other. You can't answer all the questions, so better to. I think your email is there. They can ask you directly also, and they can see the class once again. The explanation is there. Sometimes people miss one or two sentences. It becomes a confusion. So I think by watching the class, they can easily be able to answer whatever the queries there.
And I hope I have not made many of you sleep, because volatile agents per se and uptake with a lot of physics seems to be much inducing than the one which we clinically practice.
You have done wonderfully well. I think this is the way to take a class, how to be more practical in taking class. You can't just go and read theory in the book and you can come with a prepared question answer. On the table, on the operation table, how the things are happening, you are very much dynamic in explanation of the facts, with the physics, with the gas laws, everything coming into the play. I think that's the way to go about it. The next is about the molecular mechanisms and microcirculation. These agents, all the inhalation agents, they are not easy to study. The research projects also very difficult to devise in our nation, because we don't have those equipment from where we can go one step further. The way that it has been written in Miller, all about the experimentation, so many different factors are there which are affecting the uptake and distribution, which are not mentioned in the books, even from gender to gender, age to age, the disease condition, the smoking part, the structure of the basement membrane, the genetics part. So many factors are there which do affect the molecular pharmacology of inhalation anesthetics, which cannot be covered in the books. But whatever the PG students require for their examinations to write and to answer in the Viva also, you have covered well. So it's almost a holistic coverage of the good topic, and you have done good. I can see the hand raise of Dr. Madhuri Kurdi. She wants to add something. Dr. Madhuri, unmute yourself and please.
Yeah, I think good evening. Can you hear me?
Yeah. Audible.
I congratulate Dr. Ashish for having covered a very complicated topic. And this topic was actually very much, it is wanted by the postgraduates. So I would like to just add something to that, that there are many actually gas laws which come into the picture here, especially the gas solubility. You have Henry's law, then Ostwald's law for the concentration gas effect, and Fick's law for second gas effect. So there are many gas laws over here which the students have to understand. And secondly, the most important thing here would be the difference between the concentration effect and the concentrating effect, as Dr. Ashish has tried to explain very much in depth. He has gone and tried to explain. So this is a never-ending problem with all the postgraduates and even with the consultants. What is the difference between concentration effect and concentrating effect? And every time the short note is given in the exam, the ulta answer is written always. So the concentrating effect applies to nitrous oxide, whereas concentrating effect is also a part of the concentration effect, that you have to remember. And the most important clinical application of concentrating effect is diffusion hypoxia. That we have to remember. And the effect of anesthesia circuit, which anesthesia circuit you're using, and the alveolar ventilation, the inspired gas concentration, all this is going to affect the transfer of the gas from inspired air to the alveoli. Then from the alveoli to the arterial blood, it is going to be blood gas partition coefficient, cardiac output, as one student just now pointed out. If the cardiac output is low, what will happen? Then the transfer from the alveoli to the arterial blood is going to come down. So the uptake is going to come down. Then transfer from arterial blood to tissues. So here the tissue blood partition coefficient, tissue blood flow, and arterial to tissue pressure difference, all this is going to come into the picture. So, so I think Dr. Ashish has covered all this, but the students will have to go into more depths of this topic to understand. Thank you.
I think since it will be online, students can always revise this and see once again. And this, is the next class will be a continuation of this thing, isn't it, Dr. Bajwa?
Yeah. Next class will be on the pulmonary gas exchange, the transportation of carbon dioxide and oxygen. Because where the analysis ends, we have to see other part also. Because majority of times those things are very important. How the things really work. It become a complete class. So next class will be taken by Dr. Deepti Saxena. She is professor and head at Aurobindo Medical College in Indore. So she will be speaking on that part. So I think all are welcome to join that class, and it will be very easy to clear the doubts which I think whichever has been wandering in the minds of the PG student, they can take part in that class also and can clear their doubts there. Anybody wants to say anything else or want to add without questioning, just want to add to this class? Anybody? They can unmute themselves and can raise hand or unmute themselves and can directly ask or add their views.
It was an excellent lecture, Dr. Ashish. No doubt, right? You have made the topic look so simple.
Sir, thank you, sir. I actually put it in, as Madam has mentioned, the Henry law, the equations, I have actually deliberately tried to put it into the lower limit in order to get this. I thought the PGs will be looking at essay question, looking at points. So I put it in that way so that they can just copy down and write an essay. And then definitely, as Madam mentioned, there are a lot of additional things which you can always look up with the laws associated with that, which you can definitely add more marks to your theory. And thanks a lot. Once again, Bajwa sir, my chair, Rajesh sir, Jolsana madam, and all from ISA for this opportunity. And with a bit of short time, I thought I can make something which is useful for the postgraduates. Thank you.
And good things come in a short time only. They can't wait for long.
It was very well explained, Dr. Ashish. Absolutely awesome class.
Thank you.
And we have got some very good reviews in the chat box also.
Rest of the Ashish, you can go through the chats, and if somebody questions, they ask the question, you can reply to them. on their emails or whatever.
Can we?
You can stop sharing a screen now, Asish,
Yeah.
so that we can conclude the session today. Just stop sharing, just when you click on the stop sharing. Yeah, it's fine now. Anybody wants to add last time? Anybody wants to add something? This class?
Sir, this is Dr. Anup here.
Yeah, please, sir. Dr. Anup, please.
Sir, the only thing is that does inhalation induction alone be a good choice, especially in the cardiac compromised patients?
It's a good question actually, because with the availability of the newer IV anesthetics like etomidate, I think it's not a good idea to go for because the MAC, the concentration, the percentage of the inhalation anesthetics will be required much higher, and I think myocardial depression, peripheral vascular resistance, all these factors, the cardiac output come into place, and when the patient is already cardiac compromised, I think that's not a good idea. With availability of the opioids and the newer IV anesthetic agents, I think a better approach is with all the research papers pointing towards the use of these balanced anesthesia in a compromised patient to at least prevent the morbidity as well as mortality. That's, I think, a fair way to go about it. What you say, Dr. Rajesh and Dr. Ashish?
I think with the advent of etomidate and short-acting opioids, it would be better to have an controlled slow induction with IV agents than inhalation agents alone. So, Dr. Anup, do you mean to have an inhalation induction alone?
So basically, morphine and inhalation agents combination is also a good combination practice. Initially, morphine and halothane was a good combination going on, but only thing that we need to is preload the patient because of the sympathetic tone loss. That was quite good maybe in a ASA 1-2 patient, but with cardiac compromise, definitely I agree with you, sir. A balanced anesthesia is a better option, and other patient safety is the utmost priority.
Because halothane
Dr. Anup,
nowadays is not used in. I think it's is it available? I don't.
Etomidate, it's available.
Halothane.
Dr. Anup,
Nowadays,
can I
is available, but what I'm saying, when the cardiac compromised patient, to be very much on the ideal side, the cardiac compromised patient should not be taken into the periphery where you have just a Boyle's machine apparatus, where you have got halothane only because of the profound myocardial depression. Even though you have added the opioids, they will not give you safe cover, because the monitoring gadgets are also not up to that mark where you can see the monitoring standards like BASE and other parts where you can monitor the volatile concentration or volatile anesthetic concentration. So ideally, when the cardiac compromised patient is there, is not advocated to be used. Definitely the myocardial depression and the loss of sympathetic tone definitely adds to the morbidity of these patients. So opioids, no doubt, the opioids are always going to be very helpful in these patients. And ideally, these patients should be, the cardiac compromised patient I'm talking about, they should be handled with very good care in a good setup and with a good monitoring standards also, because we are more concerned the patient safety than rather than verifying ourselves that we have achieved a very good anesthesia with even with the low resources. So I think that's the better.
Sir, can I just add one point to that?
Yeah, please.
Dr. Anup, if I'm right, your question was patient with a cardiac compromise coming for anesthesia, isn't it?
Yes, sir.
Can volatile agents be the choice?
Yeah, definitely, sir.
The first option will be, the first question is the cardiac patient, what is the ejection fraction? Number one, if the ejection fraction is less than 30% or 35%, the best option is opioid. It is opioid, and opioid induction, nothing else. If the ejection fraction is more than 35%, you can think about other agents like etomidate. Coming to volatile agents, as I already mentioned earlier, it is though not the first choice in any of the volatile induction in an adult patient, it can only be used as a combination. So opioid, one word, volatile agent in one word as an induction choice for patient with cardiac disease? Absolutely no. Number two, coming to halothane, it is again a big no for a patient with a cardiac disease because it causes hypotension, it causes myocardial depression. Number three, it causes arrhythmias because it sensitizes the heart to catecholamines. So a patient with cardiac disease, as Dr. Bajwa has rightly mentioned, you don't take this patient anywhere near to the patient with halothane or a volatile agent. If at all you have only an option, please go with desflurane, sevoflurane, or isoflurane. Isoflurane being the best option.
Can I come in, please?
Yeah,
Yes,
please,
sir,
Dr. Bharat, please.
sir.
Yes, sir. I just wanted to know, sir, where can we see this class again?
Sir, it is available on the website, ISA website. You go
Okay.
to the ISA website, you try to log in, or you can just openly also, you go to the classes are there. A link is there. Online PG
But that
class.
is on website.
Yeah. So you have to visit the website, sir. ISA
Okay.
website, isaweb.in.
Thank you very much.
Thank you, sir.
Thank you.
I think we have covered almost everything. And with that, time is quite almost 8, I think. Yeah,
Yes, sir.
it's 8 o'clock. I think it's better to say good night now, because next Monday also we'll be meeting almost for the same class continuation. So I'm really thankful to Dr. Rajesh as well as Dr. Asish, Karthik for doing such a wonderful job in teaching the PG students, and Jyosna and all my colleagues in at least handling these classes very well. I think, for conclusion, I just want to add something. If you want to have some more improvement in these classes, something more to be added, we can always have a room for improvement. You can directly contact me, or you can mail me also, so that we can modify the classes accordingly. Because these classes are the PG students, and they are done by the best faculty of the country, and these are available on online also, so that the student, it become easy for them to prepare for the examination. So with all that, like to say good night to everybody, and thank you everybody for taking participation in this class, and hope to see you in the next class on the next Monday at 6:30 p.m. sharp. Good night from the headquarters, and thank you everyone.
Thank you.